welcome everyone. Good evening, good afternoon. Thank you for joining us again for another live webinar series. Today, our topic is venous manometry. We have Dr. Stephanie Chen from the University of Washington. She is a neurosurgeon, and she will give us a rundown on venous manometry. And we have welcoming back Dr. Visish Srinivasan from the University of Pennsylvania. He is a neurosurgeon, and he gave us a lecture on venous sinus stenosis. So thank you for coming back. Please, anyone, if you have any questions, feel free to place it through the chat, and we promise we will send it through to Dr. Chen so she can mention it during the discussion. And if we miss it throughout this lecture, we'll be sure to email you within the next couple of weeks. And if everyone can just double check that they have their mics on mute, except for the speakers and the moderators, we would greatly appreciate that. And I will turn it over to Dr. Chen. Thank you.
My name is Stephanie Chen. I am at the University of Washington, and today I'm going to be talking to you guys about venous manometry for idiopathic intracranial hypertension. And feel free to interject at any point with any questions or any points of discussion. Happy to take any questions as we go. So idiopathic intracranial hypertension, previously been called pseudotumor or benign intracranial hypertension. However, we've since learned that it's certainly not always benign, but it's essentially a syndrome characterized by elevated intracranial pressure, papilledema with an absence of abnormal findings on CSF analysis or mass lesions on MRI. And this disease can be difficult to diagnose and treat because patients can present with a lot of non-specific symptoms. Most commonly patients complain of headaches. However, the features of the headaches in IIH patients are variable, not necessarily specific to IIH. They can be like migraines, they can be throbbing, lateralized, pulsatile, or they can be intermittent or persistent, daily or less frequent. One of the things that seems to be more common in IIH patients is that they actually have retrobulbar pain and mild pain with eye movement or globe compression, and that's somewhat more specific for IIH. But the second most common finding is transient visual obscurations. So patients may describe photopsias or flashing lights, which can then progress slowly to vision loss or diplopia, often associated with a sixth nerve palsy. The other thing patients commonly complain of is pulsatile tinnitus. Over 50% of patients have pulsatile tinnitus, but then there's also other things like cognitive disability or neck stiffness and back pain, which are also commonly reported. So this is a disorder that primarily affects females of childbearing age who are overweight. And there was this data and the last slide come from the Idiopathic Intracranial Hypertension treatment trial, which was a prospective trial of North American, both private and public centers. And actually in that trial, they also noticed that 5% of patients report a family history of IIH, which suggests that there may also be a small genetic component. And a number of medications and exogenous substances have also been linked to IIH, although it's a little bit difficult to study, but things like growth hormone, tetracyclines, and vitamin A have all been linked. In order to make the diagnosis, you really need three things. You need a lumbar puncture, which shows an opening pressure of greater than 20. Have to have an ophthalmologic evaluation. And typically what we see here is papilledema. And papilledema comes in a number of grades. So what you see here is the optic nerve, and the top left here is normal. You see nice sharp borders on it. And as the intracranial pressure builds in the head, there's compression on the optic nerve, which causes blurring of the disc and eventually hemorrhage and vision loss. In addition to an ophthalmologic evaluation, as I mentioned, an MRI is necessary to rule out any mass lesions that could be causing elevated intracranial pressure. Other imaging findings that you may see, pretty commonly an empty sella is mentioned, and this essentially is when CSF pressure builds in the subarachnoid space, and it can actually herniate through the infundibular hiatus of the diaphragm into the sella, and then pushes the pituitary gland against the floor of the sella. And so people describe this finding on an MRI of an empty sella. But other things also can indicate elevated intracranial pressure. Oftentimes you'll see flattening of the posterior sclera, you'll see distension of the perioptic subarachnoid space, you might see some enhancement of the optic nerve or tortuosity of the optic nerve. And then oftentimes you'll even see that bulging, that sort of like papilledema in the MRI where you see bulging of the optic nerve into the globe. So that's the importance of the MRI. But why does the CSF pressures sort of build up in IIH? Well, we have to know this, the normal pathway. So CSF is created by the choroid plexus in the ventricles at a rate of about 20 cc's an hour. So continuously being produced throughout the day with an amount of about 500 cc's over the course of a day. And so all of this circulates through the brain, goes through the subarachnoid space and out to these little cauliflower structures called arachnoid granulations into the venous sinus. And so CSF pressures and venous pressures are coupled by arachnoid granulations, and you really see unidirectional flow through these granulations at a pressure gradient of 3 to 5 millimeters of mercury. So that pressure gradient is really important and really plays into the pathophysiology of IIH. And, you know, IIH is called idiopathic disease because it's a syndrome with multiple mechanisms. And it could be that there's increased CSF production, there could be reduced drainage across those arachnoid granulations. And more recently, we've really focused on this finding of increased venous sinus pressure from venous sinus stenosis, but also in combination with perhaps increased abdominal or intrathoracic pressures, as well as other factors such as inflammatory factors or impaired lymphatic drainage. So this is what makes the management a little bit heterogeneous at times. We know that weight loss works really well, but it's really hard to lose weight when you have a constant headache or you're losing vision. So medical management includes things like diuretics, acetazolamide, topiramate, Lasix, and then we get to our surgical options, things like CSF shunting, which is associated with many revisions and complications. There's optic nerve sheath fenestration, however, that tends not to treat the headaches and only treats the visual loss. And then there's endovascular flow optimization. And because I'm a vascular specialist, that's sort of what I'm going to be talking a little bit more about today. So the role for an endovascular treatment comes from the observation that there is a significantly higher incidence of venous stenosis in IIH than in the general population, and up to even 90% on an MRV in the IIH population. So why is that important? So the hypothesis is that patients may have an initial moderate elevation in ICP from factors like weight gain or hormonal changes, and this increase in pressure compresses the venous sinuses. Because they're venous, they're much more collapsible and compliant. And so when the pressure builds up, it collapses these sinuses, causing an obstruction of the venous outflow. This then reduces the CSF absorption, which then perpetuates the cycle of having increased intracranial pressures. And so there's this positive feedback loop happening that becomes a vicious cycle. And this is supported by studies that have demonstrated that you can lower intracranial pressure and by doing an LP. And what happens is you actually see the stenosis or the veins actually dilate afterwards, which suggests again that there's this extrinsic pressure on these veins. So the idea is that if you can stop this positive feedback loop by eliminating the effects of sinus stenosis through venous stenting, we can theoretically end this cycle of increased ICP and more venous compression. Does it work? This is a review that showed that sinus stenting was significantly better than our other surgical options, such as optic nerve sheath fenestration or shunting, at improving vision, improving headaches, and improving papilledema, with the exception of bariatric surgery. However, what you notice is that the complication rate with bariatric surgery is significantly higher than sinus stenting. So Stenting seems to be really effective with a very low complication rate. But how do we know who to stent? We said IIH is multifactorial, and it's likely that the treatment is so successful in that review because of some element of patient selection. So this is a classification scale that was actually proposed by Kyle Fargan, who's out of Wake Forest. And he sort of describes different pathologies of IIH. There's the patients who are normal weight, but have severe stenosis causing an increase in sinus pressure. And these patients are likely to benefit from venous stenting. Whereas you have patients who have high central venous pressure due to heart failure or due to high intrathoracic or intra-abdominal pressures without any venous stenosis, and so they're less likely to benefit from venous stenting. Or you have patients who have a combination, so they have high intra-abdominal pressures, but they also have this venous stenosis, and again, those are patients that are more likely to benefit. So the first thing in distinguishing the patients who will benefit is to identify the venous stenosis. So for the medical students who are in the audience, there is a deep venous drainage system and a superficial one. And the superficial one is where the sinuses are. And there's a superior sagittal sinus, and these drain into the transverse sinuses bilaterally into the sigmoid sinuses and down into the jugular bulb and the internal jugular vein. And in this picture, it looks like, everything is really equal and perfectly symmetrical. But what we do know is that the venous system is highly variable, and there's a lot of anatomical variation between people. So you may see a picture like B or C and think, oh, well, there's venous stenosis on the left here, or there's, a venous occlusion on the left there. But actually, it's very common for patients to have right-sided dominant venous sinuses. In fact, 43% of people seem to be right transverse sinus dominant, with only a third of patients being co-dominant, and then a minority of patients being left-sided dominant. In general, males tend to have larger severe sagittal sinus and dominant transverse sinus absolute calibers when compared to females. And then many patients, or 10% of patients, have what's called a bifid superior sagittal sinus, where rather than a single sort of torcula, they can have a triangular division of the posterior superior sagittal sinus of varying heights. And in fact, there's a non-zero rate of stenosis even in the general population. And even when you look at stenosis in the IIH population, it doesn't seem that the degree of stenosis on an MRV or CTV necessarily correlate with severity. And so how do we know what's a pathologic stenosis? And so this is where venograms and venous manometry become very important. So this was a study where they looked at the correlation between stenosis on a venogram with the pressure gradients and the ICPs, and they found that only 30 to 35% of venographic stenosis is necessary for there to be a significant pressure gradient. And after that, it seems like every 10% increase in stenosis on the angiogram seems to be associated with a 3.5 millimeter mercury increase in pressure gradient. But this is on the angiogram, and so it's a little different. What they found was that the MRV and the CTV did not have high enough sensitivity to demonstrate that same finding. But just doing the angiography and the venography is not enough. We see that venous anatomy in IIH patients can actually be quite similar to normal patients in that they tend to be right-sided transverse sinus dominant, with 43% being co-dominant, and they seem to have slightly smaller calibers of their dominant transverse sinus and superior sagittal sinus, with a slightly larger caliber of their dominant sigmoid sinus, which may suggest that there's a post-stenosis dilatation. However, they're actually pretty similar. So really what we're looking for is that stenosis. And typically that stenosis in IIH occurs most commonly in the transverse sigmoid junction, which seems to be most susceptible to compression. Second most common area is the posterior sigmoid sinus, with the torcula and the jugular bulb being the least common. But again, we know that there's stenosis. We want to know what's pathologic, and so that's where this venous manometry really becomes important. So this was one of the first studies in the 90s where the authors performed venous manometry in combination with a lumbar puncture and demonstrated that these numbers actually correlate very closely. And so I'm going to tell you a little bit about how we do it at the University of Washington, starting with the pre-op planning. So we typically get an MRV pre-op to assess the venous anatomy and to see whether the patient has a dominant sinus. We like to wait at least 2 weeks after their last lumbar puncture. And again, that's because we saw earlier that after performing a lumbar puncture, oftentimes that venous stenosis dilates, or we see dilatation of the venous sinuses on the on the angiogram, as well as on intravascular ultrasound. We also stop any medications or diuretics that they're on at least 48 to 72 hours before the venogram, again, because these medications can give you false negative results. The next question of awake versus general anesthesia comes up a lot. There were these two studies that were done in 2017 and 2019, which looked at awake venous manometry and general anesthesia for venous manometry. And this first study demonstrated that even though the numbers seem slightly higher in anesthesia team on the anesthesia cohort, they found that significantly fewer patients had gradients greater than 8 when under general anesthesia. Similarly, this paper also found that the gradient was significantly lower in the anesthesia cohort. And so for this reason, we generally perform venous manometry awake and in a separate setting from stenting, which we generally do asleep. However, this was a more recent study with even more patients, again, out of the Wake Forest group, where they actually found that there was no significant difference in the gradient while under general anesthesia versus awake. But the caveat was that it was really important for anesthesia to maintain the end tidal CO2 in the 38 to 40 range, and then also keep the patient's MAP within 20 of their awake values. So, so the point here is that if you have a highly sensitive patient where they're not going to tolerate the venous manometry awake, it is possible to do it under anesthesia, and it is possible to do the venous manometry in the same setting as stenting. And then in terms of access, this is a paper we wrote up describing the use of the basilic, cephalic, or brachial veins in order to access the venous sinuses. And we prefer the arm because patients generally prefer it, and then it's also a little bit of a shorter trajectory. In terms of equipment, if you're only doing venous manometry, a 5 French system is really sufficient. So we'll use a 90 centimeter 5 French Envoy with an XT27 microcatheter, which will navigate with a 014 microwire. And then, the important thing prior is to make sure you have your arterial line pressure monitoring set up, which we hook up to the anesthesia monitor. And the reason that we use an XT27 or at least an 027 microcatheter is because there's this study that was done where the authors used a programmable pump and they tested the microcatheters in a closed circuit, mimicking no stenosis and pre and post of a focal stenosis. And they found that the 027 had the most reliable results, followed by the 021 microcat. This is the 027. This is the closest to, they found that all the microcatheters produced recordings that were slightly higher than the true recordings, but this 027 was the closest to the real recording. And then the 021 did a little bit better. And then the 017 did the worst, which they essentially said was unacceptable as pressure monitoring devices. So important to use at least an 027 microcatheter. And then in terms of where to measure, so it is important, one, to always zero the pressure transducer right in that mid-axillary line before you start, to ensure that you have accurate and reliable pressure measurements. And then if the patients are co-dominant, we'll go out and do the left transverse sinus first. So we come up the right, usually the basilic vein into the right IJ, thread our microcatheter out to the left transverse sinus. We'll do a venogram from the left, and then we'll navigate our catheter out to the internal jugular, hook up to our pressure monitor, zero it, and then pull back slowly, starting from the IJ to the jugular bulb, taking measurements at the sigmoid, and then left transverse sinus. If they have a unilateral sinus, or after we complete the left side, we'll pull the catheter back to the right transverse sinus, do a quick venogram, and then navigate our wire out into the sigmoid, superior sagittal sinus, do another venogram, and then starting from the anterior third of the superior sagittal sinus, take a pressure measurement, pulling back to the middle, back to the posterior, to the torcula, and then back to the right transverse, to the sigmoid sinus, jugular bulb, and then into the IJ. So how do we interpret the results? So the question is, what is a normal venous pressure? And the answer is actually, we don't really know. So we take these absolute measurements from the venous sinus, and really what we look at is the gradient. And the thought is that a normal pressure in these small studies is between 16 and 18 in the superior sagittal sinus, and a gradient is between 0 and 3 in normal patients. However, we really don't know what's normal and what influences the gradients and the absolute pressure. And so there's actually a current prospective clinical trial measuring normal venous sinus pressures. What we do know is when things seem really pathologically high. And so the gradient threshold for stenting is actually a little bit controversial. I think most of us use a gradient between 8 and 10, and the basis for this cutoff seems to be derived from the experience of skull-base surgery, where Spetzler described, safely sacrificing a sinus if the sinus pressure at the time of temporary occlusion was less than 10. And so people have used 8 and 10, but it's actually pretty heterogeneous in the literature. So there's a number of studies where people used even lower gradients of 4 and found that they had 92% or 83% success in improvement of symptoms. This was a study where they used gradients even less than 4 in 9 patients and found that all patients improved. And then this was a systematic review, which was a little bit larger, where again, the threshold of 8 was used, but the average gradient was actually much greater, 18.5, and they found 87% improvement in symptoms. And then this was a more recent review looking at 186 patients, and they actually suggested a gradient of 21, which seems significantly higher than I've seen used by most practitioners. But they saw a difference in gradient between 21 versus 18, where 21 had 94% success, whereas patients with the gradient of 18 was closer to 83% success. So what do we use to determine who's a good venous stenting candidate? So like I said, at least 30% stenosis. We choose a transstenotic gradient of greater than 8. We look for bilateral stenosis if patients are codominant or unilateral stenosis of the dominant sinus. And that's because you really only need one good side to be draining properly in order for there to be good venous outflow. We generally prefer that patients have been attempted on medical therapy and have failed or don't seem to tolerate the side effects. And then in patients with rapid progression of vision loss, we will also stent, but we typically look for a little bit higher of a gradient to make sure that they don't just need a shunt up front. One thing that we do at our shop is 3D rotational venography. So a lot of people advocate for doing both a arterial angiogram and a venogram at the same time. We found that by doing 3D rotational venography with a sort of longer, more prolonged power injection and a little bit of a delayed picture, that we can get adequate pictures that we can see the sinuses really well, and it obviates the need for an arterial angiogram, which can also have side effects and its own risks. And this is our setup for a venous stent. We typically start off with an 8-French destination guide sheath, and then we use a 6-French shuttle or a benchmark into the sigmoid sinus, and then we'll use a 4 or 5 French Bernstein catheter out to the torcula or superior sagittal sinus, and that's when we do our 3D rotational venogram. And then from there, we can plan out exactly what we're going to stent and what length we're going to stent, and we typically use the silver stents over an Asahi 018 wire. So while complication rates after stenting are quite low in the order of like 2 to 3%, one of the common things that we see is stent adjacent stenosis, which people have reported in the order of 9 to 10%. And this is a case that we just did last week where the patient was stented and noted visual improvements initially. And you can see this was her original stenosis, and then we stented her from here to here, covering that stenosis. But she came back to the ER 6 weeks later complaining of blurred vision, and we repeated her angiogram, and you see this stent adjacent stenosis right here. And this is really the most common location that you'll see the stent recurrence is the medial transverse sinus. And so this is one of the reasons that a lot of people advocate for stenting all the way from the torcula down to the sigmoid sinus, which is ultimately what we did. We added another stent right here. And so many people will upfront just stent from the torcula all the way to the sigmoid sinus. And this is another case that was in the literature of a patient who had posterior sigmoid sinus stenosis and had a gradient of 15, and so they stented up front. And then after stenting, they checked the gradient again and did manometry and noted a gradient of 3, but you can see already that there's a little bit of stenosis there. And so when the patient failed to improve over the next couple of days, they did another venogram, and you see again that there is a stent adjacent stenosis right there and a new gradient of 25, which they stented all the way across. And you can see at the end a gradient of 6. And so again, one of the things that they mentioned is that one of the pitfalls may be that they measured the gradient from too close, and that if they had actually measured the gradient from here, the post-stent gradient would have been much larger than 3 and would have clued them into stenting further along the superior sagittal sinus than they had. And so while it's not universal practice, it sort of brings up the question of post-op manometry. There seem to be a few predictors for stent adjacent stenosis. One is a very, very high opening pressure on LP, and the other is a persistent post-stent gradient. So this was a paper out of UVA where they looked at the post-stent gradient, and they found that if patients' post-stent gradient went down to the lowest number, that there was a 0% chance that they were restented, whereas if the gradient remained either high or sort of became an average of the two numbers, that these patients were more likely to develop stent-adjacent stenosis and require another stent. So in conclusion, venous stenosis has an integral role in the pathophysiology of IIH, and venogram and venous manometry are both necessary for patient selection in terms of who gets a venous stent. Venous stenting is associated with really good outcomes. In over 85% of patients, they get symptomatic relief and very low complication rates in the order of 2 to 3%. It may be that a longer stent construct can help prevent stenosis recurrence, but further studies are sort of necessary to determine the gradient threshold, which stents to use, and which patients might benefit from some kind of combination therapy. So I know that was pretty quick, but I am happy to take any questions and would love for some discussion from everyone.
Thank you so much, Dr. Chen, for the presentation. I was curious if you could touch on antithrombotic therapy pre and post intervention, as well as if you could give us some insight into whether you plasty the stent after you deploy it, and what makes you choose between the two stents that you touched upon.
Yeah, absolutely. So we generally load our patients on dual antiplatelets about a week before stenting. And that's another reason that we'll do our manometry and stenting in 2 separate sessions, is because we don't feel that, we want to make sure patients need a stent before we load them on aspirin Plavix. And then we generally keep them on dual antiplatelets for 3 months. And then if they're improving, then we'll drop the Plavix and drop the aspirin to 81 milligrams. I know some people do 1 month, some people do 6 months. So it's a little bit variable and dependent on individual practitioners, but that's sort of been our protocol here. And then in terms of your other question about angioplasty, we never angioplasty the stents after. I think that adds a level of increased risk, particularly in the venous sinuses, of rupturing the sinus. And typically we see really good radial force from the stents that we use, the Zillow stents. So it doesn't really require angioplasty, but maybe Dr. Srinivasan also has some thoughts about that.
Yeah, Stephanie, that was a great presentation. Even though I gave a talk in this very forum, just a couple months ago, I still learned something new. I think you did a great deep dive into the literature, pulling out some of those really excellent articles. So I have a few, and I'll be kind of monitoring the chat. So please go ahead and put questions there. I really like your 3D retrograde venogram technique. Those are fantastic pictures. I personally do my 3D studies from the arterial side with a venous delay, usually around 11 seconds. But I just wanted to kind of get into a little bit of the weeds of exactly what catheter you're doing the microinjection through, where do you position it, and do you ever have issues where it's not filling properly, and then how do you troubleshoot that?
Yeah, so we actually do a 4 or a 5 French catheter, typically a 4, into the posterior third of the superior sagittal sinus, and you can get that up with an 035 guide wire. And then we do an 80% saline, 80-20 saline to contrast in a power injector, and then we do a 9 for 45 injection with a 1 second delay, and that lights up the venous sinus pretty well. I've never actually had an issue where it didn't show at least the dominant sinus well enough to know exactly where the stenosis is and how large to size the stent.
Gotcha. So you're not actually completely pushing against flow. You're pretty deep in the venous system already, and then you're kind of letting it flow out.
Yeah, it manages to light up the superior sagittal sinus as well, pretty well.
Right.
So there is a little bit of that retrograde flow, and because there's so much saline, it sort of allows it to flow against the normal flow. But yeah, it's a little bit further than I think we would normally do, like a microcatheter. So we're able to get it all the way into the superior sagittal sinus in the posterior third of it. Then you can get a pretty good injection.
Fantastic. Jay Dolia has a, a nice question. Do you see any future in OCT, optical coherence tomography, for venous stenting?
In terms of, so I think OCT is already used by the ophthalmologist in IIH for monitoring the optic nerve and how well patients do in terms of their papilledema. But I think you're probably referring to OCT intravascular. And yeah, I mean, I think it's similar to sort of some of these studies that they've done looking at intravascular ultrasound, where you can look at stent apposition and you can determine how much stenosis is there, and then upon recurrence. I think the technology is just not as widespread right now, that everyone has it available, but certainly I think it would be possible and useful.
Yeah, I'll make a brief comment. I haven't used OCT myself yet. I'm trying to get it here at our center. I will say, because of its proximity to the bone, this is actually somewhere where I think OCT could shine relative to doing a cone beam CT, because you're so close to the bone. It's sometimes hard to see and make the opacification just perfect to see how well opposed it is. Whereas and the issues with taking OCT intracranially in the arterial system are less of a concern in the venous system, because we could put much stiffer catheters through these more durable veins, durovenous sinuses, and so if you can get a 6 or 8 French catheter through your stent, then it's a chip shot to get your OCT system and then just unsheath, as we do with the stent. Next question I had for you was, do you do venous manometry in follow-up routinely, or you kind of wait and choose based on symptoms?
So I can tell you, most people here do not. I'm sort of still going to be developing my own practice, and I think I would do it post stenting immediately, but in follow-up, I think it would only be in patients who are symptomatic. If patients fail to improve, or if patients are noting persistent symptoms, then I would bring them back for manometry and venography again.
I think that makes a lot of sense, especially you showed some really nice data showing that the manometry under GA is actually quite reasonable. You might not be able to exactly compare it to a conscious sedation pre-op number, but at least you can see if there is any elimination of gradient. But the data you showed on longer stents was also kind of interesting. So with the Zilver, how long do you usually go? And have you followed the recommendations of that paper? And are you going routinely to the torcula, or only in cases where you get recurrent stenosis?
Yeah, we're really routinely going to the torcula and trying to stent the whole segment. So the Zilver stents go up to 80. Sometimes that can be a little bit more difficult to push up there. So, and depending on whether or not they're available, either 2 stents, like a 40 and a 30, or using the 80 or 240 stents are both feasible. And we typically do that all the way from torcula to at least transverse sigmoid junction. Is that how you guys?
Yeah, I'm also early in practice. So far, I've been using the Zilver. I've done a few 50s and a few 60s. I will say that the 60 didn't feel any different than the 50. So I feel better about going longer, because I also, if there's any, and these stents oppose quite well and drop almost exactly where you want them to. But I feel like during the deployment, if my catheter system backs up at all, I have a little bit more insurance with a long stent. So I haven't gotten 80 yet, but I do think that I might reconsider based on what you've shown.
Yeah, absolutely. And I also think that using one single longer stent is a lot easier. We have had trouble getting through the first stent if it's not distal enough. So using one longer stent, if it's available, I think obviates the problem of getting through a brand new stent rather than waiting and bringing them back.
Yeah, I think that makes a lot of sense. there have been, you probably saw recently, there was a JNIS paper kind of more focused on pulsatile tinnitus workup, but certainly overlaps with our IIH patients in terms of kind of a very extensive workup for pulsatile tinnitus in terms of doing provocative maneuvers, looking down low for stenosis in the internal jugular, kind of combining this with an Eagle syndrome workup, doing head turning, doing, Valsalva maneuvers. Is that something that you have seen, or do you kind of do it on a case-by-case basis?
So in patients who have pulsatile tinnitus, we will first see them in clinic and try and do some of the, the compression tests. They see the ENT as well to rule out any of those causes. They get an MRV. And then the other question is, how much does it bother them? I find a lot, some patients will say, oh, I hear it here and there. And then you're like, well, do you want a procedure where you get a stent, have to be on dual antiplatelets? And they're like, absolutely not. But if it's really bothersome to them, we'll do an angiogram and a venogram and look for IJ stenosis or jugular bulb dehiscence and consider stenting if we can reproduce those symptoms and they're quite bothersome. So yeah, I mean, we've been doing actually a number of different things. One is if they have some kind of dehiscence, we'll do a web or stent coiling. If they have stenosis, then we'll consider venous stenting.
That makes a lot of sense. And the last question I had, this was also from the chat. In light of these interesting findings, is it your recommendation that every suspected case of IIH undergoes venous manometry in addition to an MRV? I'll kind of add to that, so someone has a diagnosis of IIH, plus minus, let's say, papilledema and increased opening pressure on lumbar puncture, but the MRV or the MRI is not very impressive. Would you still take that patient for manometry or consider?
Yeah, I mean, I think in light of the fact that an MRV and CTV have been shown not to be all that sensitive, and that you only need a 30% stenosis for there to be a significant gradient, I think if patients are willing to undergo a venogram and undergo venous manometry, which tends to be, a pretty well-tolerated procedure, I would be willing to do it.
Yeah, I think that I totally agree with that. I mean, the most obvious case for me, my very first venous manometry case was a patient who kind of ticked all the boxes in every other way, but did not have an impressive MRV. And I was just going to shoot an arterial side angiogram and that delayed venous phase and do my 3D rotational venogram from the arterial side. But my partner kind of nudged me into doing venous manometry, said, hey, you should really consider it. You don't know what you'll find. And it's certainly worth just, considering, just at least you never know what you'll find. And lo and behold, she had a huge gradient, stent her the following week. And, she's been one of my happiest patients since.
Yeah, it's really remarkable how little stenosis can produce such a large gradient, unlike something that we see on the arterial side. I found it really surprising on multiple accounts where you're like, that's it, that's the stenosis, and there's like a gradient of 20 millimeters of mercury or something.
Right. We do have one more question in the chat. So you kind of mentioned, it's difficult to kind of counsel these patients at times. So can you kind of briefly talk about the bedside manner aspect of IIH, and maybe rolled into that, if you want to just comment on what other specialties or what other physicians are involved in treating IIH at UW, and then how do you guys kind of work together?
Yeah, I think the neuro-ophthalmologist is one of the most important people for IIH patients. They are oftentimes the first to diagnose IIH. They are oftentimes the people who do the LP, and they're the ones who can monitor the symptoms best by examining the papilledema and doing visual fields. And so they're really critical to the team. But in terms of speaking with the patient, again, I think it's pretty well tolerated. Venous manometry, you know, it's done under light sedation. You go through an arm. It's like getting an IV put in. Sometimes they hear like a little bit of whooshing when you put the microcatheter in there, but other than that, patients tolerate it very well. So I tell them, you know, it's a diagnostic test. It's pretty minimally invasive. There's very low risks, especially because we're in the venous system. And then once we have all the information, venous stenting again has a pretty low complication rate. And it doesn't preclude any of the other treatments. So obviously, if patients have like fulminant IIH, you worry about doing DAPT in the case that they can't get a shunt. But even in those patients who I look for like a slightly larger gradient, I still don't think it completely precludes them from the IIH, because you could easily stop the Plavix, and you know, many people only do the DAPT for about a month, and so there's still a possibility of a backup option.
Yeah, I think that makes sense. And yeah, of course, to temporize them until they get the shunt, you might be able to safely pull off, you know, a proper image guided lumbar puncture under aspirin. I think is quite reasonable. I think. Yeah, that was great. Like I said, I learned a lot. I hope the rest of the folks listening did too.
It looks like we got it all in. Amazing. Thank you so much, Dr. Chen, Dr. Srinivasan, for your expertise and your time in this discussion. It's been very helpful. We have people from around the world on tonight. Someone stayed up till midnight to listen to you. So we're very grateful for you guys to come on today. And we look forward to our next lecture. It's a very deep dive, but it's on lymphoedema of the brain in association with IIH with Dr. Stephanie Link. She is an interventional neuroradiologist in Paris, and the moderator will be Dr. Pierre Gobin. He's an interventional neuroradiologist from Weill Cornell Medicine, and it will be on Wednesday, May 17th at 9 a.m. for Pacific time, 6 a.m. if you want to wake up super early. Thank you guys again for your time, and we look forward to hearing from you soon.
Thank you.
Thanks.
Thanks, everyone.
Bye.